All right, so first innovation that I'd like to talk about. So I'm actually going to touch on some of the themes that the other panelists talked about, that many of our future innovations in antiplatelet and antithrombotic therapy are going to be little to do with new medications. As Tim said, it's going to be, or as I guess Bill Gates said, it's going to be the implementation of the medications that we already have. And one example is the use of cangrelor amongst patients who haven't been pre-treated before their PCIs, and trying to abrogate the risk of intraprocedural thrombotic complications. In this case, cangrelor was associated with fewer in-procedure complications, specifically stent thrombosis, and we looked at how much do these events cost. Because we're often in hospitals focused on the acquisition costs of drugs or stents or devices or procedures. And in the cath lab, it led to an increase of about $3,000, $6,000 to the hospitalization, a periprocedural MI around $4,000. And if there was a stent thrombosis, you can see how exceptionally expensive it is to deal with these types of procedures. For us, we do a procedure, we lose the side branch or the vessel shuts down, we deal with it, and we're usually giving high fives to each other, saying, we got out of jail, but maybe there's a better method to avoid this in the first place. We now have the ability to reverse anticoagulation amongst patients receiving DOACs. The ANNEXA 4 study led to the approval of a Dexanet. This is something I don't know. Our hospital, we don't have it. Does anybody have it available, Tim? You guys have it? So not yet. There's kind of a staged rollout, but what I'll tell you is this is going to, I think, release the intellectual burden that we have against using some of these medications that may be associated with risk of bleeding, but our worry is that we wouldn't necessarily be able to reverse it. These are some of the outcomes related to the utilization of this medication, stratified by type of DOAC and a number of different factors, but in general, the use of this medication was associated with achievement of hemostasis. I showed this slide a couple of days ago of my partner, Mike Gibson, having run the Pioneer AF PCI study, looking at around the 20% of patients who have atrial fibrillation associated with their PCI and rivaroxaban-based therapies versus what we consider the gold standard, which is triple therapy, and just drawing your attention to the clinical outcome, which was a reduction in bleeding. This is where I want to draw more attention to today, is the implementation of this strategy. And I think our panelists and you all agree that we can do the best PCI in the lab, and then when we transfer the patient either to the floor or home, and we're not communicating effectively of what the anticoagulant, antiplatelet strategy can be, we end up with situations that may be dangerous for the patient. We looked in our own database and found that we have hundreds of patients that are discharged on dual antiplatelet therapy with full dose DOAC. And that's because I did some angioplasty, transferred them to the floor, and then someone had a few minutes of atrial fibrillation, and we had such an exceptional push to get the people out of the hospital is someone starts them on full dose rivaroxaban. And I just point out to you here, the reason why Mike chose 5 milligrams as the dose that goes along with dual antiplatelet therapy is the 10-fold increased risk in fatal bleeding associated with just the 10 milligram dose, let alone the 20 milligram dose that some of these patients are going on. And remember, in this trial, the vast majority of patients had clopidogrel, but you can imagine the mix and matching that is occurring with full dose of this plus full dose of ticagrelor or prasugrel, and I've had a TIA in the past and such. So I think this is a major threat in implementation to our patients, and I think being able to deal with this in some of the ways that Stephen brought up will be helpful. But also, as we look at costs of implementation, these were the costs of rehospitalizations in this trial. And you see that though the medications cost a little bit more, or depending on your perspective, a lot bit more, overall, the cost to the system was reduced because of fewer rehospitalizations and cardiovascular event costs. So shifting gears, it has already been mentioned that we're kind of ramping down on the duration of dual antiplatelet therapy and looking at it with current iterations of stents, utilizing shorter duration of DAPT amongst patients who are deemed to be at high bleeding risk. I was talking with some electrophysiologists, and they were discussing, really innovative strategy of putting left atrial appendage closure devices in patients who had just received stents to try to reduce the time that they're on triple therapy. And I looked with, kind of puzzle at this, and they were saying, well, you guys got to have people on dual antiplatelet therapy for a year, and with warfarin, that's going to lead to a lot of bleeding. We should put appendage closures into these people. And I said that's kind of state of the art 5 years ago. We're going to be having shorter and shorter duration of DAPT, and as I showed you in the slides before, we're not going to probably be using triple therapy in the first place. So I think having conversations with our colleagues too about what should be the proper strategy. Other studies that are looking at shortening the duration of DAPT amongst high bleeding risk patients, ongoing Science 90 study run by Roxana Meron, also run by her, is a 1 month study, and ramping up right now in site selection is a 1 month study with the Onyx stent. This was shown earlier, the Twilight study that Roxana is also running, looking at avoiding dual antiplatelet therapy in the 12 months after this 3 month period of using dual antiplatelet therapy. And I think it makes sense to us that the immediate threat to the patient who's just had a stent is stent thrombosis. But that risk decreases substantially over time, and shouldn't we tailor our therapy to that declining risk, whether that be reducing the aspirin or changing agents? I think these are going to be coming strategies. So to summarize, new drugs and strategies will do things better. We're going to do things safer. We're going to do things more efficiently. We're going to have to question long-held paradigms. And these things are going to benefit not only the patients, but overall the healthcare system. And with that, I'll stop. Thank you.
Can I ask you, I think this triple therapy is becoming, for everyone, a nightmare. Everyone has questions, what should we do, what should we not? And since you're the innovation person, what should we do right now for in triple therapy? People on warfarin or NOACs, and they have PCI. What should we be doing afterwards?
So my practice right now is to utilize clopidogrel and rivaroxaban, or clopidogrel and dabigatran, because those are the regimens that I think are associated with the lowest risk of bleeding and have the most data behind them. That may be inconvenient. That may require checking with pharmacies and how much are the patients going to have to pay. That may actually take a little bit of extra work to deal with. But if there's also these kind of unconventional reasons to be on triple therapy, like we're worried that they have akinetic apex, or they're on it for pulmonary embolism prevention and such, then I may change what I do, but they have cancer, for example, and we want them on Lovenox. And so there's all these scenarios, but I think trying to keep up with all of this, and as well as involving my colleagues, hematologists and other interventional cardiologists, trying to come up with standardized protocols too, is important. We have some hard stops being developed in our OMR so that we can't order some of these regimens that we think are associated with worse outcomes.
So you give the 15 rivaroxaban, or you give 20 rivaroxaban for the people, since 15 is not available, right? So how do you deal with it? Give the standard 20 dose?
Yeah, so we can get the 15, we can't get the 5. So we can't do the DAPT with 5 milligrams of rivaroxaban yet. But I think, as was shown earlier, between Compass, Atlas, and Pioneer, that soon we should have that 5 milligram dose approved.
So, Duane, I would say, this is an issue where we have great agents. It's how we apply them, right? And so two I'd like to talk about is, if Kinglor was free, we'd use it in every case, right? Because it's like immediate on great P2Y12 inhibition. So one is, how do you deal with the costs, and how then do you apply it to the patient populations of who you need it? The second one I want to say is, no one's a stronger believer in standardized protocols than me. But this issue about anticoagulation post-PCI, the AFib patient and how long you do DAPT, if there's ever an example of where we need personalized approaches, it's that. So it's probably the hardest area to do standardized protocols.
Yeah, I think, there's the intersection of risk scores and rules that really kind of hurt us. Like how I call it the tyranny of the CHADS in the hospital, is because we can calculate a CHADS VAS score, everybody believes that stroke risk is the most immediate threat to the patient who's just, undergone a PCI, when in the short term, stroke is probably not their biggest, stroke prevention is not their biggest problem. That's one thing, but you're right, setting up these protocols is difficult. Trying to implement them is probably even more difficult, trying to get everybody to buy into them. But I do think that trying to avoid actually some of these red lights, like regimens that are dangerous, I think is actually relatively easy. I think you had another question.
Well, the other one was, how do we do, like, for instance, Cangalore, right?
Oh, yeah.
Pharmacologically, it's perfect, right? But it's the cost, and it's then who do you apply it, and when is it worthwhile? Because I don't think that we're that great at stent thrombosis has gotten to be so low, we're not great at predicting who it is. Where do you optimize it? How do you do that?
Well, I think that's why I showed some of the costs of events, is that there is some, equipoise between our understanding of giving a bunch of medications that cost a lot to people who aren't going to have an event versus the cost in an infrequent and unpredictable group of patients who do have an event. And, I think, it's maybe for Stephen to comment on too, as a health delivery person, is, how do you reconcile when the pharmacy budget is held by one group and they're charged with reducing costs by 25% over the next year, but the CEO is actually who cares about what things really cost.
Yeah, absolutely. Yeah, you need that. It comes back to that synergy and that operational buy-in, so that the folks that at a higher level can say, I understand that you live in this silo and are responsible for these dollars, but for our system it's beneficial, and so we're going to have that trade-off that's actually beneficial for our system in general. So it requires that higher degree of oversight and operational buy-in. Otherwise, you're right, you won't succeed. We run into the same issues for trying to get patients out of the lab. So the floor that the patients are supposed to go to has kind of their set budget and their operational flow, and as a result, they meet what they need to do, but it impacts upstream of them in terms of getting patients out of the lab, and we have patients held. And so we need that higher level of operational oversight to say, we're going to allow this to run a little bit cost negative so that we can be cost beneficial in one aspect and help our overall health system.
It becomes really complicated to think about all of these things. So for example, I'll give you a real world example from last week that I'm dealing with, which is a hospital about 45 minutes away that is owned by our hospital wants to have an elective PCI program. They transfer about 150 PCIs to us, and so this is like great idea, right? It's great for patients, they don't have to transport, all the ones that, all these things. And so what happens now, instead of getting transported up 45 minutes to us and having same day discharge maybe, or discharge the next morning, they go to ICU because they're a new program and they need to learn, and it's so unsafe and all these things. So now you have 150 patients that are going to ICU for a day or two and staying in the hospital when they would have been discharged from home from the cath lab after a 45-minute transfer. And who's in charge? And then all the variations of, well, that hospital is owned by our hospital, so what's the financial incentive there? And if it wasn't, what would that mean? And all of these things. And this is where we're all tools within the larger, machine, but we made it that way.
You're pointing out all the complexities, and especially if you've got each individual hospital is responsible for its own profits and loss. They become, the large system's a holding company, and as a result, you can have each individual hospital maybe is doing well, but if you were to kind of synergize efforts, you'd do much better. but that requires a high degree of operational oversight and to understand those issues.
Yeah.
And when they create incentives so that the hospitals are actually competing with the health system as opposed to optimizing.
Mm-hmm. Mm-hmm. Any questions from the audience or comments? All right, well, with that, I think this is a really fun session, and thanks for joining us. Have a good rest of the meeting.